to Barry and Christoph for providing us with the opportunity. Sorry, that's my phone ringing. For Craig and I to share a perspective on learning and living. And I think that in our time at GEMS, my time at GEMS during this period, I've come to understand the importance of data, and I also now know what an actuary is. And many of you know that the person I spent an enormous time with at Insight is Craig. And from 2016, on a Friday and a Monday, my routine was as soon as the early warning report came out at Friday o'clock at 2 o'clock, I would call Craig and we would engage on the report. So what we're going to do is share some of the learnings together during my time at GEMS. What we learned now recently during these challenging COVID times. And finally, what does this mean for our future? So we're going to talk to a number of dilemmas, and there are many over the coming slides. But firstly, I just want to talk about the importance of data. And I think in these last 6 months, our understanding of mathematics has increased exponentially. We've all learned about data, models, and charts. And I think in the Foresight sessions, we've seen a lot of that shared by people like Christoph and Barry and Craig, etc. We also know that we've seen an exponential increase in data and connectivity through the fourth industrial revolution. And we hear of the FANGS group of companies, and now more recently, Zoom and MS Teams. And this meeting is an example of the explosion of virtual connectivity. But also, we need to, certainly for people like myself, learn from old truths about the future. And my favorite hero in the world is Warren Buffett, and he talks about compounding, which is the 8th wonder of the world, and the importance of saving and investing. And I think I'm going to come back to that and highlight how important this is into the future. And then finally, the issue of debt and debt spiraling at an individual, company, and country level. And we've seen South Africa now heading for a debt of over 80% by the end of this year, and over the next 2 years, over 100%. Can go to the next slide, please. So there's an abundance of dilemmas that we're going to touch on. And the first one that we all have been dealing with is COVID. And we know that we're now at just under 700,000 cases with 17,500 deaths. But more likely, if we take a better indicator with the collateral effects of COVID, over 40,000 deaths. And a big dilemma that we're all talking about is, will we face a second wave? And I think that when we look at what's happening now in Europe, we can safely say that there's a strong likelihood that South Africa will also face a second wave. However, it's likely to be smaller and less severe. And this is based on the fact that we had a massive first wave, and the data from the Western Cape, which showed that almost 35 to 40% of people were exposed to COVID. We go to the next slide. Then what we've seen that last year on Time magazine, we were highlighted as the most unequal society in the world. And it's not something that we want to be recognized for, but the tragedy is that we now become even more unequal. Our economy is struggling, and we saw on an annualized basis, our GDP shrank by 50% in the second quarter, and for the quarter, almost 16%. South Africa has the fastest growing debt, as I indicated, and amongst the top 20 emerging markets, it has the fastest growing debt, except for Argentina, and that's not good company to keep. And we're heading for a debt spiral, and 22 cents in every rand that our budget is allocated goes to interest payments. On top of all of this, we're seeing the corruption that we experienced historically and now particularly related to COVID. And this highlights that good governance and ethics matters. Go to the next slide, please, Craig. And then three ongoing dilemmas that we face as a country, and again highlighted by the COVID period and amplified, is access to healthcare, education, and land. In the healthcare space, this last 6 months have highlighted the absolute need for a strong public healthcare system. In terms of education, the lockdown has highlighted the gap between the rich and the poor and those with access to technology. The loss of direct teaching and social interaction for children has been magnified. And then finally, in terms of access to land, housing, small-scale farming, food, water, and sanitation is now the new epidemic and emergency in our country. But our founding father of our country, Nelson Mandela, said it's not where you start, but how high you aim for that matters for success. And while our challenges are tremendous, they are not insurmountable. We as South Africans have a history of overcoming and achieving the impossible. And again, during this COVID period, we've seen the tremendous coming together and collaboration by many parts of our society to respond to the COVID pandemic. My own experience being part of Doctors on Call is one small example of this collaboration. Doctors on Call operated over a 20-week period from April as we entered the lockdown up to the end of August. 150 doctors responded daily as call center agents working remotely to provide essential information and advice to the public. Over 15,000 people were assisted during this period, highlighting the power of collaboration and the use of technology. Another great example was a collaboration between government and business. Business for South Africa supported government to respond to the pandemic through PPE provision, data and modeling, testing, medicines, equipment, and oxygen. Insight supported the data modeling through Barry with the Actuarial Society. And I do believe together we are stronger and can achieve the impossible. So, Craig, we're now going to spend the next part of the presentation just sharing with you, learning from our past, lessons from GEMS, and learning from our present, lessons from the COVID-19 experience. And underpinning all of this is that you can't manage what you can't measure. And I will hand over now to Craig.
Certainly, as Dr. Guni already mentioned, there's tremendous value in being data-driven. As a country, as institutions, as individuals, we should learn to approach our decisions based on data rather than sentiment when tackling our challenges. We also need to establish mechanisms through which we can swiftly analyze data, because in a fast-moving world like today's, yesterday's data really is yesterday's news. So to highlight the importance of having up-to-date data, we need to understand how quickly our world is changing. So in just a few weeks, our world and our country fundamentally changed, and our data needs to keep pace accordingly. So in this particular slide, we show the Sunday Times headlines over the course of a month or two. In the middle of February, the Sunday Times headline was referring to crash test dummies. It was referring to vehicular safety. And that's an important topic, but certainly COVID was just a faraway concept at that point in time. It was something that was happening in China, in Italy, but didn't really affect South Africa. And I think there was very little focus on it in the South African context and from a data analytics perspective. Just a month later, South Africa was swiftly heading towards a lockdown. So in the course of a month, our country and our world fundamentally changed. And the pace of change didn't subside after that. A week or so later, the headline refers to God Save South Africa. And certainly there was, I guess, a sense of a patriotic or nationalistic battle against an invisible enemy in the form of COVID-19. But again, 2 weeks later, I think the messaging had changed quite significantly, and South Africa was now faced with severe economic and social consequences due to the lockdown. So whatever we do, wherever we analyze, we need to be able to keep pace with our changing world. And I think sometimes as actuaries and as decision makers, we're tempted to say, well, we don't want to make a decision just yet. We don't want to do the analysis just yet. Let's wait for there to be better data. Let's wait for there to be more data. Let's wait for there to be more reliable data. And often that's the right approach when one has the luxury of time. But in the context of COVID-19 and other pandemics, one simply does not have that luxury. One needs to make decisions fast, and one needs to make decisions based on data, so one needs to have the data readily available. And I think two of the key lessons that we've learned through this process is that one has to be willing to be wrong. One has to be willing to change their stance. As more data emerges, as we learn more about the pandemic, one has to be able to say, what we said before had merit, but our views have changed, and these are the reasons why. And I think that's a tremendously important lesson. And it's one that we learned in the GEMS context previously. So certainly GEMS is an organization that under Dr. Guni Goolab adopted a data-driven approach underpinned by a variety of early warning mechanisms. I'll give one example where a data-driven approach was highly successful. So it's certainly no secret that in 2016, like many other medical schemes, GEMS faced certain financial challenges. The GEMS reserve ratio was approaching 4%, and there was significant pressure on the GEMS finances. At that point in time, GEMS adopted a data-driven approach underpinned by early warning mechanisms, and what we saw was a swift and significant change in reserve ratio. By the end of 2017, the reserve ratio escalated to 15%, by the end of 2018, 25%, and it's since escalated further to in excess of 25%. And certainly I don't want to suggest that the only reason that GEMS was able to achieve such a strong financial position so quickly was because of data analytics and early warnings, but it certainly was a significant contributor. Now, in the context of COVID-19, we've seen that the pandemic has been characterized by an abundance of data analytics and early warning systems. It really has been the hallmark of the pandemic. And certainly I think what this should make us consider is, are there any missed opportunities out there? Where else could we apply the strong data-driven approach underpinned by early warning mechanisms? And I think there are many opportunities for this. Just to give a few examples, the South African Police Service and crime statistics. Imagine how useful it would be if on a weekly basis, the South African Police Service published detailed crime statistics uploaded into dashboards. It would empower stakeholders to better understand crime trends. It would empower the police themselves to more proactively tackle crime. And then much the same for Eskom. Imagine a mechanism through which they tracked capacity and demand on a weekly basis and made that publicly available. And I think in truth, it's something which they have begun to do. If you go to the Eskom website right now, there are various dashboards to that effect. And certainly national government could produce similar statistics on employment. So at this point, I do want to put up two questions for a poll. And I guess ask the question to the audience. The first is, would it be a good or bad idea for public and private entities to make more decisions based on data rather than sentiment? So to be data-driven organizations. The second question is, would it be a good or bad idea for public and private entities to publish certain of these reports to facilitate public discourse? So I'm going to go on to the next slide, assuming that most of the audience thinks that both of those 2 points are good ideas. But with that in mind, I'm going to say, given that we're talking primarily to a group of healthcare stakeholders, given that it's a great idea to be data-driven and to perhaps release some of that data to key stakeholders to facilitate discourse and discussion, how many medical schemes out there are monitoring and managing their claims on a weekly or even monthly basis? And how many perhaps are only monitoring and managing their claims quarterly when it is perhaps a little bit too late to react. So how many healthcare providers regularly monitor the value proposition which they deliver to patients, both in terms of the cost and quality of care, and how much of this information is released to members and patients? So to put it simply, where are the dashboards and publications on the other pandemics which we as South Africans face, such as chronic disease? So certainly there is tremendous work done by many schemes and many healthcare providers in this regard. I wouldn't want to create the impression that there isn't, but I think it's fair to say as an industry, there is the potential to do more. I'll hand over again to Dr. Guni. Dr. Guni?
Sorry, I realized I'm mute. Apologies. Over the next few slides, we're just going to go through some of the challenges at an individual, company, and country level. So if we take at an individual level, over the last 6 months, we've seen, whether we talk from a physical, a financial, or social well-being point of view, we've seen that there's been a major reduction in cancer screening consultations for chronic screening. A major medical administrator experienced 42% reduction in wellness and screenings for chronic conditions, a 51% reduction in mammograms performed, and 30% fewer GP consultations for chronic conditions during lockdown level 5. The Western Cape Health Department experienced a drop of 42% in primary healthcare visits to their facilities, a 12% reduction in immunizations, and a 48% reduction in surgical operations. All of this compounded by job losses and income for millions of our people. Finally, we have seen an increase in psychosocial issues, including stress, anxiety, depression, and gender-based violence. Go to the next slide, please, Craig. At an organizational level, you need to start from a position of strength to survive and thrive in this period. And we have seen many companies under severe pressure during this period. Just 2 examples in the private sector are Tongaat, Hewlett, Adcon, and Adcon is now in financial review. And in the public sector, SAA and Eskom are well-known examples. And we thought we'd use GEMS as a great example of a successful organization that is well-positioned to cope with this type of extraordinary, once-in-a-lifetime risk impact. There are many learnings from the GEMS experience for all organizations, both public and private. Some of the key learnings that we will briefly share, the GEMS built up over the past 6 years. And the first one is that it has a strong financial position, as Craig mentioned earlier. And this is crucial for individuals, companies, and a country to ensure that it deals with its financial or debt position. The second thing we learned from GEMS and we're learning in our country is that governance matters. GEMS dealing successfully with fraud and corruption head-on is a great example. Using data on a weekly basis, as Craig described, with the early warning system based on hospital auth is a key way for organizations to succeed. Measuring outcomes through disease management, shown in the HIV, diabetes, and hypertension space in the CMS report. And then ensuring a focus on service and a strong collaboration with all key stakeholders, including the PSCVC and the service providers working through the claims and service management program. And all of this underpinned working closely as a scheme with its data provider and actuaries. I'll hand over now to Craig.
So certainly one of the best examples where GEMS has contributed towards the financial and physical well-being of its members would be the Emerald Value option. So the Emerald Value option is an option which was established in 2017, and it has a number of unique features. The most unique features which it has relate to primary care, preventative care, and care coordination. So every member on the Emerald Value option is required to nominate a specific general practitioner and then go to that general practitioner for their primary care. Also, before consulting with a specialist, they need a referral from their nominated general practitioner. At the same time, GEMS has contracted with general practitioners, specialists, hospitals, and other healthcare providers to ensure that they deliver a strong value proposition in terms of high quality of care at an affordable cost to its members. That contracting is also supplemented with profiling and peer review. Simultaneously, there are particularly rich benefits for preventative care, be it screening, monitoring of chronic and acute conditions, and vaccinations. In return for embracing care coordination, members on the option receive a 15% discount relative to the equivalent option in the absence of care coordination. So certainly, the first few points which I mentioned, primary care, preventative care, care coordination helps to ensure the physical well-being of members, and the contribution discount helps to ensure the financial well-being of members. So to illustrate the point further, we can compare the costs which are incurred on the Emerald Value option, so the option underpinned by care coordination, relative to the conventional Emerald option, which is exactly the same option with exactly the same benefits, except that members are not required to embrace care coordination. So what we see is that the costs incurred by members on the Emerald Value option, the healthcare costs incurred by members, are significantly lower than the healthcare costs incurred by members on the Emerald option for each and every cohort of members, for different age groups, for different genders, for different chronic statuses. So certainly this does impact this does highlight the beneficial impact which care coordination and a commitment to primary and preventative care can have. And we believe that if these principles were applied across the private sector, approximately 20 billion Rand could be saved a year. And certainly that would help with the financial wellness side of the equation. Our Minister of Health, Zweli Mkhize, I think put exceptionally well when he said, COVID-19 exposes all of the weaknesses in our social and economic structures. It's worsened the situation by those conditions such as poverty, unemployment, and inequality. It challenges the basics of our human rights in society. So essentially what we're saying here is, although COVID-19 is a virus which makes one physically ill, it certainly has a far broader social and economic impact. And that is something that we need to consider when making our decisions. So as per the GEMS example, we as stakeholders in the healthcare sector, as medical schemes, healthcare providers, we should be thinking about how we can contribute towards a healthier society and by implication combat COVID-19. In particular, we should think about how we can make people improve the physical well-being of our society, and we should be thinking about how we can tackle the pandemics of chronic disease which COVID-19 feeds on. So on the left-hand side of this particular slide, we show an analysis which we did on the Insight Data Universe, which looks at what impact do various chronic and acute conditions have on the likelihood of developing severe COVID-19. And what we see is that for each and every chronic condition, it has a significant impact on the chance of developing severe COVID-19. For example, asthma. Having asthma increases the chance of a severe infection by 60%. And whilst I'm not going to run through each condition, just to highlight one or two particularly significant conditions, chronic renal failure increases the chance of a severe COVID-19 infection by over 350%, and diabetes by over 100%. So as stakeholders in the healthcare sector, we need to think about how we tackle these chronic conditions so that we can tackle COVID-19. Simultaneously, we need to find ways to make the healthcare sector more affordable. In the current economic circumstances, I think business as usual and the lack of affordability associated therewith is a significant challenge. I'm not going to go into further detail on the financial challenges facing our country and our citizens. I think Dr. Guni mentioned that sufficiently earlier when he spoke to the 50% decline in gross domestic product and unemployment, and for the expanded definition seeing it close to 40%. We really are in a difficult position and need to find new and innovative ways, such as the GEMS example, to challenge the financial difficulties which we face. Finally, there is often the concept of social solidarity is often mentioned in the confines of medical schemes and health. And certainly it's traditionally been thought that social solidarity is there to protect the vulnerable. It's there to protect the sick, and it's there to protect the poor. I think what COVID-19 has actually shown us is social solidarity is there to protect everyone. Ultimately, we either all sink or swim together. So in the context of COVID-19, it just takes one person to get infected, and that one person can infect 2 more or 3 more or 4 more. And then those people can infect even more, and it quickly exponentiates. So really, and that will impact on persons irrespective of their health status and irrespective of their financial status. So it really is, we all either sink or swim together, and we need to account for that learning when making our decisions. So I'll hand over again to Dr. Guni.
Thanks, Craig. And I think what Craig and I want to wrap up with now is just to share with you some of our thinking around the way forward. We go to the next slide, Craig. And I think we've tried to say that we need to acknowledge our challenges, learn from the past and the present, and understand the value of data in making smart decisions for the future. Go to the next slide, please, Craig. And I think we want to close off with just sharing, what can we each do practically as individuals or families, and what do we do as communities or the country? So if we look at ourselves as individuals and families, and where appropriate, supported by our employers, the first thing we've tried to demonstrate is that managing your finances and reducing debt is absolutely crucial. We all need to work towards ensuring our expenses are less than our income, and that we need to adopt what we would call a balance sheet mindset, where we're all making sure that we're building our assets and we're reducing our liabilities, building assets through saving and investing, and reduce liabilities through reduction of debt. And as I mentioned earlier, my guru and mentor is Warren Buffett, and he says that the most valuable asset is yourself. And you should constantly invest in your own learning through further education and skills development. And I think at this time, I would urge all of you to continue to invest in yourself. And then the third aspect is to focus on our health and wellness and controlling of chronic conditions. Ensuring eating healthily, daily exercise, adequate sleep, and avoiding smoking are some of the basics of health and wellness. And I read a NEJM publication that showed that just 15 minutes of exercise a day, or consistently over a number of years, can increase life expectancy by 10%. And then in terms of controlling of chronic conditions, and we know many of us have them, is to ensure that there's regular follow-up by the GP or specialist, there's compliance to chronic medications for hypertension and diabetes, and then monitoring of those conditions through tests, data, and analytics, such as BP and HbA1c. To the next slide, please, Craig. So at a community and country level, what are some of the things that we need to prioritize? Well, one of the ways is, as Craig has outlined, the importance of the interdependency. And we need to look at how we can turn at a country, company, hospitals, or school level. For example, partnering of schools between rich and poor schools, collaboration of companies big and small, twinning between trading regions such as South Africa and Sub-Saharan Africa, including countries such as Ghana and Kenya. And I think one of the issues that we all have to now accept, and COVID has highlighted that, is that given our high levels of unemployment and inequality, we do need to seriously consider converting the COVID-19 grant of 350 Rand into some form of basic income grant. I believe it's essential, needed, and probably unavoidable. We need to understand the interlinkage between economy and healthcare, and I think COVID has brought that to the fore. We need to look at how we deal with our economy systematically, dealing with issues such as access to water and sanitation, affordable housing, agricultural partnerships between large and small scale farming, implementation of the necessary healthcare reforms through the HMI and NHI recommendations, leveraging the 4IR technology, supporting entrepreneurship, particularly in the townships, in the township economy, and then coming back to what I had highlighted earlier around the government debt reduction, which is now heading for an unsustainable level, dealing with the public sector wage bill and SOE debt, dealing with corruption, both in the private and in the public sector, and we see early signs of moving towards it. And then, some of the learnings we had from when we were young, there was a saying that goes, each one, teach one, and each one, employ one. Go to the last slide, please, Craig. So in closing, from Craig and I, we'd like to say that all of us can, at an individual, family, company, and community and country level, contribute and make a positive difference. As our president stated, we shall recover, we shall overcome. Together, we are stronger. Thank you.
Thank you, Guni and Craig. So I am presenting next, so I'm just going to start sharing my screen. So today I'm going to be speaking about mental health, and I think the timing of this presentation is probably quite good. Sorry, just give me a second. Okay, there we go. So yes, I'm speaking on mental health today to give you some perspectives there. And I think the timing of this presentation is actually quite apt. This past weekend was World Mental Health Day, and I'm sure a lot of you have seen some stories in the media around mental health and whether we should be expecting a psychiatric pandemic in the next few months. So I'm going to show you some of the scheme trends and try to answer some questions on this. So today what I'll try to answer is looking at whether depression is increasing. If so, what might be leading to the increase? Should we be preparing for a psychiatric pandemic? Who suffers from mental health issues? What are the kind of risk factors for mental health issues? What are some of the causes for poor mental health? And this is quite interesting to look at during this year, specifically looking at causes that might be linked to the COVID-19 pandemic that we are experiencing this year, and then what trends we see in medical schemes at the moment. So this is more of a COVID-related presentation, but there's still some broader ideas on mental health to think about. So usually when someone starts speaking about mental health, there's an onslaught of statistics of the millions of people who suffer from mental health issues. And while that's useful to understand the enormity of people struggling with mental health issues, you can sometimes lose sight of the individual and the experience that they have in dealing with mental health issues. So I think a useful way to reflect on the experience that an individual has in dealing with major depression is thinking about the defining symptom of major depression, which is anhedonia. Anhedonia is an inability to experience pleasure. So you can imagine an individual who is just so plagued by thoughts in their mind and feeling so down that they, you tell them a joke or show them a sunset, and they, it's difficult for them to appreciate the good things in life. So I think just reflecting on that definition alone is quite depressing, and really makes you think about the individual and what they're going through. If they're experiencing major depression, it's quite a devastating disease. But yeah, we are am reflecting on major depression. You do also get different levels of anxiety and stress. All of us, through work and financial issues, cope with a lot of stress on a day-to-day basis. But major depression can be really a tragic disease, quite devastating. As I mentioned, it was World Mental Health Day this past weekend. So here is some stats around mental health. In young people, it's the second leading cause of death, which is quite scary. 1 in 3 South Africans will suffer from mental health issues at some point in their life. So if you think about an individual suffering from poor mental health, this leads to a decrease in their mental health and physical health. It leads to an increase in suicide risk and a decrease in their quality of life. Another impact of poor mental health is that, particularly in this area, we see quite a big indirect cost. So these are indirect costs due to lost productivity at work. So this is where people might be going to work when they're feeling depressed or have some other anxiety disorder or mood disorder that prevents them from working effectively. So here you can see this is based on a European study of disorders of the brain, and you can see mood disorders, the indirect costs are over 50% of the total cost related to mood disorders. So the lost productivity that employers feel as a result of these disorders of the brain is also significant. So here you can also just see that in South Africa, when people suffer depression, they do tend to go to work, so they don't always take time off to deal with their issues and try and recover from their depression. So you have people not taking any time off and still going to work, and that impacts productivity. Now I'm going to chat about some of the causes of poor mental health, and here I'm going to draw on some content from Robert Sapolsky. He's a biologist and also a professor in neurology at Stanford, and he's got a lecture series on stress in your body, and he's written a few books. He's also written a book on stress-related diseases that you can see there, and I think we have to trust what he says, given that beard that he has. I think that beard looks like it's been grown out of pure wisdom, or otherwise, I don't know, he just likes people asking him to be Santa Claus every year. But yes, I'm going to be drawing on some of his content in the next few slides. Some of the causes of mental health issues, the causes can either be biologically related or psychologically related, or sometimes they are just problems in life that we have to deal with. So some of the biological problems, there is a certain degree of heritability associated with depression and other mental health issues. Hormone imbalances can also cause mental health issues. So a lot of us are familiar, where women are at risk after childbirth of suffering from depression. But there are other hormone imbalances that can also impact depression and mental health issues. So when you have imbalances in your thyroid hormones, that can also lead to depression. There's associations there. And there are also stress hormones called glucocorticoids, which also can, when they're out of balance, can lead to mental health issues. And there are also other healthcare conditions which can lead to depression. For example, some medication related to reducing blood pressure and used for managing cardiac patients. There's an association where it actually influences some of the brain chemistry, and that actually leads to depression as a side effect from the medication. And of course, there's other conditions like cancer, which are just very difficult conditions to deal with, and having to struggle through those type of very difficult conditions can also lead to depression. Then there are also psychological problems which lead to depression and mental health issues, such as lack of outlets for frustration, guilt, trauma, and different occupations can be exposed to different levels of trauma. For example, our healthcare workers at the moment, they're experiencing quite a lot of burnout, but there's also quite a lot of trauma emotionally in having to deal with patients, having to deal with their families, having to deal with death. Police officers also, quite a lot of violence that they might have to deal with through their occupations. So trauma can affect different occupations and lead to different mental health issues. Some other psychological problems is a feeling of a lack of control, lack of predictability, lack of social support. I'm going to come back to those ones in the next slide. And then just some problems that, many of us have to deal with. As Guni and Craig mentioned in their presentation, GDP is declining, we're experiencing high levels of unemployment. So if you've had a reduction in your salary or you're unemployed at the moment, that financial stress and that work stress can be quite a heavy burden to bear and lead to mental health issues and depression. And also, it's quite a difficult issue to fix. It depends on our economy. Then people can also suffer from grief, and this is also particularly topical this year, where you might have had loved ones in hospital and you might not have been able to be with them. Maybe they've passed away and weren't able to be with them. Grief can also be applied more broadly to losing concepts. So suffering grief because of marriage or divorce, or suffering grief because you're middle-aged and you realize that you're no longer young and you go through a midlife crisis. So a few of the causes of anxiety and depression that I just want to come back to that are psychologically related are lack of outlets for frustration, lack of control, lack of predictability, and a lack of social support. And the psychological research highlights these areas as some of the main causes. And I think hearing me chat over these causes probably, you can reflect on each of these through the lockdown that we've experienced this year. I think a lot of us felt like there was so much uncertainty and we didn't know what each lockdown level was going to entail, and when kids were going to be able to go back to school and when we would be able to go back to the workplace. For some people, going to the workplace is actually a way to release some frustration. Going to the gym is a way to release some frustration, and all of that, has been lacking this year during the lockdowns that we've had. And of course, given COVID and social distancing, it's also been difficult to reach out for social support. You can only really, reach out to those who are really close to you during lockdown. We couldn't travel to family and friends to be with them to get social support. And there is some research that shows both social isolation and loneliness are associated with increased mortality. So this really is quite a big risk factor, and social integration is also associated with a lower risk of physiological dysregulation. So basically social integration is better for your health, and this study measured social relationships quantitatively by asking people how many social relationships they have, what's the frequency of interactions that they have with family, and they compared that against different biomarkers like BMI and waist circumference and blood pressure over time. And what's interesting that's also come out of this study, it's from a couple of years ago, so it's not a recent study after our experience through COVID-19, but they've also found in this study that a greater perceived quality of your network is also associated with better health. So this was a bit more of a qualitative element of their research, where they asked people about how they perceive the quality of their relationships, and that's also better for your health. So it's not just the number of social relationships you have, but it's also very important that they're good quality people that you can connect with and rely on in order to support good mental health and better general health. So who is impacted by mental health issues? If we just take a look at the medical schemes environment, and we look at rates of depression over ages, here we can see that women have much higher rates of depression there in the pink, and men have lower rates of depression. And we can see that that relationship is maintained throughout age. The gap between women and men actually gets bigger with age. You can see men, during their 30s, 40s, 50s, the rates of depression actually looks fairly stable there and only starts to increase towards your 60s for men. But you can see for women, the rates of depression increase throughout all of the ages. We also have children who suffer from mental health issues, depression. So it really impacts everyone on the age spectrum: children, adolescents, people in midlife, and it also impacts the elderly. So that was just looking at depression. If we look at mental health and behavioral disorders more broadly, again, we see quite a similar trend where women have a higher rate compared to men. But what's interesting here is that we see in the age group of 5 to 9 that boys there have a higher rate of behavioral disorders. So this is where boys are actually diagnosed with hyperactivity disorders. And again, thinking about this related to COVID-19, you can imagine for parents having to deal with a child who has a hyperactivity disorder during times, where they had to stay in the house, and during lockdown must have been extremely challenging, not only for the parent, but for the child as well. So, really challenging times for people in terms of their mental health. Are levels of poor mental health increasing? Again, if we just look at data within the Insight universe, and we look at the percentage of people suffering from mental health issues from 2012 to 2019, we see an increase of about 4% on average there for lives with poor mental health. So that's kind of a typical increase that we'd expect, for additional disease burden or additional utilization from one year to the next. So there's a question then, are there particular age groups where there's bigger increases? And if we look at females, young females, adolescents, and also young adults in their 20s, we see quite a consistent increase here from one year to the next in terms of the percentage of females suffering from mental health issues. So an average increase of about 10% for these age groups over the years. So here we definitely see quite a consistent pattern of increases, and I don't have the figure for males, but you don't see the same pattern there. In some years there are very small increases over these age bands, or in some years the percentage of men suffering from mental health issues has remained quite stable, but the increases are a lot smaller than we see here for females. So we see that trend within medical schemes, and the international literature also suggests that there are higher increases for adolescents and young adults in terms of mental health issues, and girls in particular. So that seems to agree with the international literature, and is definitely quite worrying if you have a teenage daughter. So, some of the international literature suggests that social media has had an impact on mental health issues for young women who maybe use social media more than men do. So now that we've got an idea of the different demographic risk factors, if we take a look at suicide and see what kind of gender distributions we see in terms of suicide, we see an opposite relationship here. So here we see men are actually more likely to commit suicide than women. So in South Africa, about 4 times more likely to commit suicide than women. And this is a global trend that we see, across most countries, about between 2 to 4 times men being more likely to commit suicide than women, but the international research does also show that women are more likely to make attempts of suicide. So if we try to take a look at what we see in terms of self-harm within medical schemes, we see that men are more likely to abuse alcohol and drugs. There you can see in blue the percentage of men who have admissions for alcohol dependence or drug dependence, whereas we can see there's a significantly higher proportion of females who have admissions for injuries or poisoning due to toxic substances. So we do see also in the medical schemes environment, again, agreement with that literature that shows that women may be more likely to induce self-harm, so more likely to make attempts, whereas men are more likely to actually commit suicide. So this is quite worrying. Given the demographics that I spoke about first, it makes it look like the picture is quite bad for women. But then when you start looking at, the end outcome in terms of suicides, where men are actually more likely to commit suicide, schemes, employers, different stakeholders can question whether their communication in terms of mental health is appropriate, and whether there's more that needs to be done in order, to communicate with men, to make them to feel comfortable if they've got mental health issues, to actually seek treatment for those mental health issues. So if we look at admissions for alcohol and drug dependence, and again, the poisoning through toxic substances in 2020 compared to prior years, to try and get an idea of whether there's any sort of increase in 2020, given the unemployment that we're facing and all of the mental hardships that we're facing in 2020. So far we don't see an increase in those type of admissions. It's still far below the historical years, and we don't yet see an increasing trend. Of course, August and September claims, there's still a bit of claims that will come in to be reported there, but you can see April, May, June, July, far below the historical years. So at the moment, we don't see an increasing trend in self-harm, but this is something that perhaps should be monitored. So again, why it's important to monitor this is that the research shows that suicide mortality increases during economic crisis, and an important risk factor here is unemployment duration. So the sooner that people can, get back to a job, that will reduce the risk of the suicide. But given the international research, we could start to see some increase in self-harm within the next few months. So now to come to the question, should we be preparing for a psychiatric pandemic? So here I'm just going to look at some overall scheme trends in 2020 compared to prior years. So these are mental health visits out of hospital, and you can see in April, mental health visits out of hospital, there was a complete decline, similar to what we've seen in other healthcare, like elective procedures and GP visits, where there's just a complete decline during April because of the lockdown that we had during that month. But you can see in May, June, July that the out-of-hospital visits related to mental health have started to increase. August is also, still in line with previous years there. So they have come closer, in the June, July, and more recent months, closer to pre-COVID levels, but perhaps not as high as one might expect, given all of the mental hardships that people are experiencing this year. So this is also something that's important to monitor, to see, if people are struggling with mental health during this year. And if we just split that out to look at the different disciplines that deal with mental health, we see similar trends across most of the disciplines. And you can see there that GPs actually rebounded a bit better than the psychologists, so people using their GPs in terms of helping to manage their mental health issues. And then if we just split out occupational therapists and the pediatricians who might be dealing with mental health issues and compare that to psychiatrists. Psychiatrists, you can see the drop off in April, and then you can see visits start to return in May, June, July. But you can see a completely different trend there for the occupational therapists and the pediatricians. They have the drop off in April, but it's a lot larger, and they haven't had the return to their normal sort of levels over the more recent months. So the psychiatrist might have been, more better placed to start using telehealth, and that might have helped the psychiatrists to maintain some of their out-of-hospital visits. But it does seem like it's been quite difficult for people to go to their occupational therapists and their pediatricians relating to mental health issues. They might have had fear in terms of COVID and being infected, and this is occupational therapists tend to deal with more severe cases of poor mental health, where they actually do functional assessments and help people with a plan to return to work. So if you have, more severe patients who are maybe off work on disability due to depression and they aren't seeing their occupational therapist to have that plan to return to work, then this issue could be continuing for the next few months and, maybe even the next year in terms of mental health, where we're going to see quite a need coming up for mental health over the next year. And then if we look at mental health admissions, here we can see that people suffering from mental health issues have avoided going into in-hospital facilities. So we see the drop off in April, and we do see a little bit of an increase, but it's not in line with historical years and with pre-COVID levels. So here people definitely have been avoiding hospital care in terms of their mental health issues, which is also a bit worrying. And then one more trend that I just want to point out here, maybe not necessarily to point out trends in 2020, because this is a historical problem where if you look at the follow-up consultations on discharge, so where someone's been in hospital for a mental health issue, and you look at whether they've had a follow-up with their psychologist or their psychiatrist within 30 days of that admission, and you see follow-ups with psychiatrists, that's only about 2% of people, and 15% of those admissions within the next 30 days have a follow-up maybe with their psychologist or their psychiatrist. So there does seem to be scope here to monitor someone's discharge after they've dealt with a mental health issue, to make sure that they get the best care out of hospital again, so that there are no relapses and perhaps they come back into hospital, or perhaps maybe a year down the line they are still suffering with mental health issues and have to come into hospital again. So far from what we can see, the out-of-hospital visits, with GPs, psychiatrists, psychologists, those seem to come back up to their pre-COVID levels, back up to historical levels over the last few months, May, June, July. But definitely in terms of hospital admissions, there has been a reduction there. So this is something that schemes have to be aware of, and there are additional warning signs that there is utilization in terms of mental health that could be coming in the next few months and in the next few years. The next year or so. We've seen disruptions in mental health over various countries. Surveys of self-reported anxiety and depression show increasing levels of anxiety and depression in the USA, in South Africa. The anxiety and depression helpline have seen an increase in the number of people placing calls there. The suicide helpline increase in people reaching out there. So there are some warning signs that there is still utilization and a need for mental health coming in the next few months, even though we don't see it in hospital at the moment. So just to summarize and think about the way forward, we've seen that a broad range of ages are impacted by mental health issues, and there are prominent gender differences. So it's important for employers, for schemes, to think about how they communicate and, get men who are maybe thinking of committing suicide, get information to them, help them to be treated, and then also thinking about those younger adolescents in the teenage years, the females, whether there's something more that can be done to try and help them with their mental issues. As I've mentioned, there are some warning signs suggesting that there could be an increase in mental health issues over the next few months, over the next year or so. We're still expecting, an economy which is going to be struggling, not just for this year, but also next year. So given the high levels of unemployment, this is, more of a long-term outlook that we maybe need to be taking in terms of mental health over the next year or so. So schemes, they maybe need to think about how they can, enhance out of hospital benefits to, make sure that people get appropriate care through their mental health programs. Of course, we know that mental health is quite a PMB-centric benefit, but perhaps there is more room here for schemes to think about how to manage the out-of-hospital benefits better to try and keep them affordable while still giving people good access to care, by perhaps implementing networks, giving people access to GPs who are trained to deal with mental health issues, which are maybe more affordable than a psychiatrist. These are going to be important things for schemes to consider in terms of their benefit design over the next year or two. And then as I did point out, in terms of the follow-up consults, this seems to be an historical problem which doesn't seem to be improving in terms of discharge planning and having a follow-up consult once you've been in hospital for a mental health condition. So still some coordination of care to be done there between schemes and providers to ensure that people struggling with mental health issues actually get proper care when they are released from hospital and there's no relapse. And as I've mentioned, I mentioned the biological problems, the psychological problems, but there's some problems that are just difficult to solve, difficult to deal with. If you're dealing with unemployment, you can't exactly just take some medication or talk to, through talk therapy, just solve that problem immediately. This is quite a difficult problem to solve. Perhaps you need upskilling, reskilling in order to find a new job. You need to see a career counselor. So there are sort of broader pathways that people can also use to deal with their mental health issues. And social support, as I mentioned, is very important for the people dealing with unemployment. The social support will also be good to keep their mental health in a better position. And where we have people who are unemployed, perhaps some of them won't be able to stay on private medical schemes, so they might not have access to private care and they would have to rely on the state. But there could be some people who are unemployed and still as a dependent, maybe as a spouse, would have access to private medical care. So this is still something for schemes to grapple with in terms of unemployment. And then just thinking about prevention, predicting who might be at risk and trying to communicate with them and, get them to get them onto an appropriate care plan would be a good way of prevention. But it's also useful to remember that, we do need stimulation, and the right kind of stress can actually be good for us. So that's just important to bear in mind when you're dealing with your own types of stress, that some stress is actually good for us, and maybe that can help to handle some of our stress. And promotion of mental health wellness can, as I say, it can occur inside the health system, but also more broadly outside the health system through social support and support in terms of trying to upskill people, reskill people so that they can be employed again. And then I want to end off by just asking a question to the audience. We've seen that mental health issues over the years do seem to be increasing, or the number of people having to deal with poor mental health seems to be increasing, while at the same time we have, an abundance of different apps that we can use to monitor our sleep, monitor our appetites, our exercise, to make sure that we're healthy. We can, there's an abundance of self-help books that we can use to manage stress. You can Google, you can go on YouTube and look for different resources in terms of self-help and managing stress. So even though we have all of these resources, and of course not all of these would be free, but some of these are free. So even while we have all of these resources that could help us in terms of managing our stress, we still seem to have, the number of people dealing with poor mental health issues increasing. So I guess that's just a question to leave the audience with and think about. Thank you.
Thank you for that, Gizelda. I think, again, thanks for everyone who's attending. We have a couple of minutes left for some questions and answers to be asked. I think the most important one, or maybe just to reflect before we move on in terms of the presentation that Gizelda just did on mental health, is just to add, there's a fair amount of international research correlating financial stress with health, and not only mental health, which is to say, if you can get hold of, let's say, credit score data or financial well-being data, you find that people with financial problems actually present not only with mental health claims, but also with respiratory and all other kinds of admissions. From a holistic point of view, all claims go up when people struggle financially. And maybe we can keep that in mind as we go forward. So we have a few minutes for questions. I think the first and the most important question from Paula is the results of the first poll. Gizelda, can you perhaps just put that up while we wait for the other questions to be answered? The one to do with all of my favorite actuarial jokes. So the definition of a computer is an actuary with a heart. At least 13 of you thought that's funny. I'm still a little bit disappointed that my favorite actuarial joke is not there. I like to point out that an actuary is apparently a place where you bury actors after they die. So thanks for this question, Paula. I hope this answers the very important question that you asked. I'm going to move on to a question for Craig and Guni. This is from, I'm not sure from whom, because it's pointed out as an anonymous attendee. I will read out the question just for the benefit of those who are watching this on YouTube. So the question is as follows. It's with regards to the second poll, the question that Craig asked about sharing of data. The question is, how much of an obstacle is the commercial sensitivity of data to its publication? So do you think it would be possible for agreement to be reached between a critical mass of stakeholders to make data publicly available? This kind of a quid pro quo, I'll do it if you do it. Or is regulation the only way to achieve this? So Craig or Guni, whoever wants to go at this, or both of you, if you want.
Okay, I'll kick off. I see Craig's not unmuting. I think it's a great question, and I think the answer is in the question. Is that I think it's a combination of both. So given that we're in the health sector and we deal with not only commercially sensitive information, but we deal with healthcare information. Ensuring adequate protection of that information is crucial. So both from the POPI Act and health specifically, I think there is a need for regulation and oversight in how data is shared. I think so that's from the regulatory side. I think from the commercial aspect, and I think it's partly goes to the question Ottawa was raising as well, is that yes, there are competitive dynamics, and people do believe that data is a form of competitive advantage. But I would argue, in two ways. One is we've seen with the health market inquiry, and the discipline with which that inquiry was conducted, and the detailed reporting that, if you structure and research information carefully, you can come with very good and sound outcomes that benefit everybody. And that takes me to the point that I think the only way you're going to get a critical mass of stakeholders to collaborate is if there is a common problem and a common purpose that everybody buys into, that the greater benefit is more than any individual gain. And I think COVID has highlighted that as an example. I think Christoph, you and Barry can attest to that from the B4SA work on the data and modeling. You've seen people come together and sharing information, which improves the quality of your decision making. And I think that that applies to everything that we want to do. So my response would be that we would need to make sure that when you bring stakeholders together, you define a clear problem and a common purpose that you want to solve together. And once you do that, the rest of the things will flow from that, Yeah. Thanks.
I think also, just to echo Dr. Guni's sentiments, I think there is regulation on its way in the form of the suggestions coming forward from the health market inquiry. But I think it's fair to say that there do remain questions as to when that regulation will manifest and how long that will take. I think if the industry does sit back and say, well, let's do nothing now because regulation's on its way, there's a tremendous missed opportunity there. It might be a tremendous amount of time until that regulation is fully in place and fully enforced. I think the other point to consider is, although the gold standard would be industry collaboration, where many different stakeholders come together and share their information collectively, I think individual stakeholders within the sector shouldn't underestimate the value within their own data. So even if it's not an industry initiative, and even if it is just perhaps 1 or 2 or 3 stakeholders getting together to share their data, that can still provide tremendous value, both to their individual members and I guess to society more broadly. So I think really my point is, perhaps whilst we should strive towards having industry collaboration, and that's ideal, one shouldn't do nothing until that's achieved. One should say, well, what can we do right now?
Yeah, so if I can perhaps just quickly add to that, I mean, one of the fascinating observations from the health market inquiry was the questions posed by the panel to the listed hospital groups. And so, as we all know, every hospital group has quite sophisticated internal metrics as to its own efficiency, the satisfaction, the outcomes of its patients, but these have never been compared to each other. Some of them are not directly transposable to each other or comparable without some analysis or some thinking, because the metrics are not necessarily compatible. But the panelists asked each hospital group 2 questions. The first one was, do you have this kind of information? And they said, yes, they have extensive information that report on internally for clinical governance and management purposes. And then the panelists asked, would you be willing to share this information for purposes of some kind of benchmarking or comparison? And without hesitation, every one of the South African hospital groups responded, yes, we would be willing to. Because this is the kind of question which, when posed from a principles point of view, all stakeholders agree is necessary. However, when you get to the nuts and bolts, there's this perceived kind of first mover disadvantage that if I go first, I might be exposing myself without really any recourse or any benefit to my shareholders. So, from a naive point of view, I guess regulation is the only way to go, and it's coming in South Africa. But another way to think about is this so-called rating agency model, which is to say some neutral agency collect data from willing stakeholders, publish this, and then stakeholders of entities who do not share their data might start asking questions like, why are you not sharing yours? So there's a snowball effect. If you can just get the ball rolling, by getting 1 or 2 or 3 industry players to start showing theirs in a neutral and a comparable fashion, you often find that stakeholders will start increasing the pressure, without using regulation, to create some incentives for this data to be shared. So you quickly get to a point where the absence of your sharing your data is perceived with some degree of skepticism. Like, why are you not sharing yours when others are sharing theirs? So this is a brilliant question, and thank you for that. We have 2 more questions from Odwa. He's joined us on the panel, so he can ask his questions live. I believe there's one question to Guni and Craig and another question to Gizelda. And I'm just going to ask right now, if anyone else has any questions, please just alert us in the Q&A, just the Q&A button at the bottom, or in the chat. If no one else asks any questions, then we'll probably close off this session after Odwa's 2 questions. So thank you, Odwa, for joining us. Again, last time Odwa joined us, he was immaculately dressed, groomed, prepared. It looks like you've done that again, Odwa. Well done. So please proceed.
Muted,
Odwa,
Dr.
you just unmute yourself, please, Odwa.
Okay, you missed that pearl of wisdom, but I'll get to drop it again. I was saying I watch Avengers a lot. If you watch it yourselves, you'll see the Incredible Hulk when he stops turning green. They ask him, so how do you do it? How do you stop getting angry? And his answer is, I'm always angry. So I'm always immaculately dressed, Christoph. I'm kidding. But thanks for inviting me on. The first question, honestly, has actually been, I think, answered in the discussion that we've had up till now. In fact, your response just now, I think, spoke to a lot of it in terms of that trust initiative that you need to get going. How do you get that ball rolling? I would have thought that perhaps there was a new push, that COVID may have heated the iron, the proverbial iron, so to speak, and that it might be hard enough to strike to say, look, if we're willing to share, sort of COVID data and we're putting it out there and it's not disadvantaging anyone, could we lift off of that? Because there's quite a bit of sharing, I think, that's happened, in the last few months. But I think, again, I won't, if it's all right with you, Christoph, I won't really pose that question again. I think it's been discussed. The second one then was perhaps an unfair question to Gizelda. Listening through what she's putting through, a lot of it is sort of personal health, depression and sort of mental health. It has 2 things. I asked the question, is there any interrelation, and that's what might be unfair, is there any interrelation between the interpersonal violence and gender-based violence that we've seen sort of really, ramp up during COVID, and either the victims or the perpetrators, having mental health issues? And there are a lot of factors, I suppose, that would need to go into making that kind of link. So that's why I say it may be an unfair question. And if there is, I was saying, is there anything that really can be done about it, rather than sit back and say, look at the stats? Is there anything that can look into and say, we can do something about this? I would have thought, sorry, I'm not even giving you a chance to answer. I would have thought that if there were something that we can do, we can perhaps better focus on sort of corporate health, so corporate wellness for those who are in the workplace. I don't think we're really touching corporate wellness well at all. And just sort of broader wellness for the beneficiary or the member who is at home, perhaps not working, but requires that healthcare. I don't think we push or extend our healthcare services, particularly mental health, to those 16-year-olds and so on who are now watching, on this media, taking the new exception as the norm, right? I have a 16-year-old niece who's telling me, Uncle, I need to go to Korea because I need to be the best whatever. And I'm saying, where did you see that? And she goes, no, there's someone on my YouTube channel that does that. And I'm going, that's 1 in 4 billion people, right? It's not the norm, it's the exception. And so maybe to speak to that kind of thing. Long question,
Thanks.
but
Thanks, Dr. Odwa. Yes, I mean, it's an interesting topic. As you mentioned, I did hear reports during this year, just news reports around gender-based violence increasing, during the lockdowns, where you have people in close quarters, perhaps with, abusive partners that just kind of exaggerated or put a strain on those relationships, and then people struggle to find anywhere else to go. It's lockdown, movement is restricted, So I did see news reports on that. I can't draw on any particular research there, but I would speculate that there is some correlation there in terms of mental health issues, probably with both the perpetrators and the victims. You know, perhaps the perpetrators abuse alcohol or abuse drugs that lead to some of these issues. And as I showed there in the stats, you know, men tend to abuse alcohol and drugs, so they can be drawing on alcohol and drugs instead of dealing with their mental health issues. So it's probably both the perpetrators and the victims there that I would speculate are impacted. But yes, as you say, you know, we need to think about mental health more broadly. You know, schemes can play a role, and the employers as well, but more broadly, you know, thinking about social programs to help these people who might be impacted.
Thanks for that. Maybe just one last comment / question from Romola. Also to Gizelda, she says there have been a few initiatives to better manage mental well-being, and she refers to the energy project and a few companies who've appointed the chief well-being officer. But the question from Romola is just whether you would suggest that the data you presented or data similar to that is shared during staff meetings to increase awareness of these kinds of trends.
Yes, I think, you know, that kind of draws on what Craig and Guni are saying, you know, that we need to be data driven. We need to use what we're seeing in the data to help, you know, strategize and deal with these issues. So understanding the different risk factors and then, you know, using those in your staff meetings to drive awareness or keep communication or different programs, I think would definitely help.
Great. Okay, thank you, everyone. I believe that deals with all of the questions, at least, or everything that I can see in the chat or in the Q&A. I believe our next Foresight session will be on the 3rd of November. Is that correct, Gizelda?
I think so, yes.
Okay. And as always, we will share today's session on our YouTube channel. We'll send an email with the links to all of you once it is ready. But it remains for me to thank everyone who attended. Thanks, Guni, especially for joining us. It's great to see you again. It's great to continue to work with you, even though you are now unattached and uncommitted to any executive positions. And so thank you very much for that, and also for Craig for the information that you shared. So cheers, everyone. Thanks. It's about 5 minutes to 10, which is the time we're scheduled to stop. For this time, we're kept to the time limit, which is great. And we'll see you at our next Foresight session on the 3rd of November. Cheers.
Cheers.